बिस्मिल्लाहिर्रहमानिर्रहीम इय्याका नअबुदु व इय्याका नस्तईन अल्लाहुम्मा सल्लि अला मुहम्मदिन व अला आलि मुहम्मदिन व बारिक सल्लि अलैहि। Dear colleagues, I am Dr. Sultan Ayub, working as a radiologist. This is my young patient with history of swelling at the right inguinal region during the coughing, standing, or doing the heavy work. So I am going to scan the right inguinal region. I have already told about the inguinal hernias. One criteria is that we put the probe in longitudinal direction and then below the umbilicus, and then when we do such thing we can appreciate the muscle in the screen. This is the rectus abdominis muscle. Then during this orientation I am moving downward following the muscle. This is the muscle belly of the rectus abdominis, and then I reaches the bone, that is the pubic bone. This one is the pubic bone, and this is the insertion site of the rectus abdominis muscle. So when we reach this level, then I move. This is the belly and this is the pubic bone. I move laterally slightly laterally until the rectus abdominis muscle is not visualized. So this is almost 1 to 2 centimeter. So when we see that the rectus abdominis muscle is not present, when we move laterally, we then come across the bone. This is the pubic tubercle. At the pubic tubercle, we just tilt the probe toward the anterior superior iliac spine. So I am tilting the probe while the probe is at the same place, and then I move laterally. Only the part of the tubercle is seen, and my probe is in direction towards the anterior superior iliac spine. So when I reach there, when this is hardly to visualize, I see the inguinal canal, and here this is the hardly to see. This is the point for the superficial inguinal ring. From here to here is the boundary, and this is the inguinal canal, and this is the posterior wall, and this is the anterior wall. Posterior wall of inguinal canal is composed of fascia transversalis from the deep inguinal ring towards the medial part, and at this level, just medial or close to the superficial inguinal ring, this medial portion of the posterior wall is formed by the conjoint tendon. Conjoint tendon is the union of or fusion of aponeurosis of internal oblique and transverse abdominis muscle. So when we move, this is the posterior wall, this is the anterior wall, which is the external oblique muscle, aponeurosis, and this is the canal And this is the point where we can appreciate the femoral vessels, and this is the belly of the internal oblique, and these this is the suprametric cord of the male within the this one. This is the vessel within the suprametric cord, and this is dipping into this, and this is the internal oblique belly, and this portion, this one is the deep inguinal ring. And if there is a defect in the deep inguinal ring, then it is the indirect inguinal hernia that lies lateral to the inferior epigastric artery, and direct inguinal hernia is medial to the inferior epigastric artery. So this was the boundary of the inguinal canal, anterior and posterior, how the posterior wall is formed by the structures. So the boundaries of the posterior wall, so the contents of the posterior wall are, the walls of the posterior wall are with the structure making the posterior wall is the fascia transversalis laterally, and the conjoint tendon at its medial aspect. So this is the pubic bone, this is the rectus abdominis moving laterally, my movement is very slow. So when I reached that there is no abdominal muscle, this is the superficial angular ring, and then now I have tilted the probe toward and oriented toward the anterior superior iliac spine. This is the posterior boundary, posterior wall, this is the anterior wall, and this is the inguinal canal. And this is the medial side of the inguinal canal, and this one is the lateral side. We have not reached the deep inguinal ring still. So we are in between the deep and superficial inguinal ring. ये जोर लो से. Here we can appreciate this defect appearing through this posterior wall. Look here. I have freezed the image to make clear. So this was the posterior wall, and this is the defect in the posterior wall through which the segment of the abdominal contents herniate during this Valsalva maneuver. We already have seen that when in the indirect inguinal hernia, the herniated contents moves through the deep inguinal ring and then travel into the inguinal canal. We are in this case, in this hernia, we have seen that the defect is in the posterior wall at the level of the medial aspect, where the conjoint tendon is also participating in the formation of posterior wall. This contents from the abdomen herniates, and then it protrude, these project in this direction toward the anterior abdominal wall, toward the skin region, toward this region, not go to this inguinal canal. In the indirect, the herniated segment travel in the inguinal canal toward the superficial inguinal ring. Here we have seen that these contents move upward through the posterior wall and to the abdominal wall anteriorly. So this is not the indirect inguinal hernia, this is the direct inguinal hernia on the right side. Again we see in the real image look here, this was the posterior wall and this is projecting outward, and if we put the color, this is the inferior epigastric artery which has been pushed toward the lateral side due to this herniated contents, this one. So this is the bowel loop under the abdomen, and this is the defect through which the bowel loop herniate, and this on the lateral side, this inferior epigastric artery has been pushed toward the further lateral side. So this defect is lying on this side, this is the medial side, so this defect is lying on the medial aspect. This is the defect on the medial side of the inferior epigastric artery. So this is the, so in conclusion we can say that this is the defect in the posterior wall of the medial aspect of left inguinal canal, through which the abdominal contents herniate during the Valsalva maneuver, and this defect lie medial. This is the medial side, medial to the inferior epigastric artery. Again, I am going to show you lower umbilical region in mid segment, in mid portion, in a sagittal direction, going downward until we reach the pubic bone. This is the rectus abdominis. Then I move laterally until the rectus abdominis is not in the screen, so is the pubic tubercle, and this is the, slightly we move laterally, this is the superficial inguinal ring, and this is the posterior boundary, and this is the abdomen where the peristaltic bowel loops are present, and this is the anterior wall, this is the inguinal, posterior wall of the inguinal canal, and at this medial aspect, this posterior wall is made up of fascia transversalis as well as the conjoined tendon, while on the lateral side at the level of deep inguinal ring, only the fascia transversalis is present here. So it means that if the conjoined tendon is weak, so it does not strengthen the posterior wall. Due to this weakening, usually, and the weakening of the posterior wall, this defect appear and direct hernia appear. So again, I am going to see it at real. And zor lo se. Look here. This another thing I forgot to tell you. Actually, This hernia, direct hernia that project into the abdomen, actually project into the Hasselbalch triangle. Here, which is called also the inguinal triangle or Hasselbalch triangle, which has boundary on this side. This is the medial side. The lateral border of the rectus abdominis muscle is present, and on the medial side is on the lateral side is the inferior epigastric vessels, and this base or is formed by the inguinal ligament. So this area where the abdominal contents herniate is called the Hasselbalch triangle or inguinal triangle. ये करो से ज़रा, look here, we can clearly appreciate, ढीला करो. So this was all about the right-sided direct inguinal hernia that lies medial to the right inferior epigastric artery at the level of the superficial inguinal ring and medial aspect of the right inguinal canal. Thank you very much.